What if we've been getting death wrong? For decades, modern medicine has relied on the concept of brain death, the idea that when the brain irreversibly stops functioning, the person has died. But not everyone agrees. Today's guest, Dr. Paul Byrne, has spent more than 40 years challenging that assumption, and today he will offer the case against brain death. A neonatologist and clinical professor of pediatrics at the University of Toledo, former president of the Catholic Medical Association, and presenter at the Pontifical Academy of Sciences in Rome, Dr. Byrne has been at the center of one of the most controversial debates in medicine. Early in his career, he encountered a patient whose chart read, quote, consistent with cerebral death. He chose to continue treatment. That patient went on to live, marry, and have children. Since then, Dr. Byrne has been involved in some of the most widely discussed cases in the brain death debate, including Jahai McMath, Aidan Halu, and others, arguing that what we call brain death may not be death at all. He is also a husband, father of 12, grandfather of 36, and great-grandfather of 5, a physician whose professional work has always been rooted in a deep commitment to the dignity of human life. So today we're asking, what is death? Are brain-dead patients truly dead? And what's at stake if we've gotten this wrong? Dr. Byrne, welcome to Bioethics, Babe. For my conversation with Dr. Paul Byrne, a neonatologist and clinical professor of pediatrics at the University of Toledo, former president of the Catholic Medical Association, and presenter at the Pontifical Academy of Sciences in Rome, who has spent more than 40 years challenging the concept of brain death, here are my 5 key takeaways. 1. Brain death and cardio-pulmonary death are not the same thing. Dr. Byrne argues that calling someone brain dead is fundamentally misleading. Death is the absence of life, and patients labeled brain dead often still show clear signs of life, including heartbeat, circulation, and biological activity. 2. The concept of brain death was not built on solid science. According to Dr. Byrne, the original 1968 Harvard criteria had no foundational scientific studies, relied on minimal data, and introduced a new definition of death largely to address practical concerns regarding organ transplantation. 3. Absence of brain function is not the same as the irreversible destruction of the brain, or death. A central distinction in his argument is that a brain can be inactive, suppressed, or recovering even when there is an absence of brain function. Therefore, diagnosing death based on function alone is unreliable. 4. True death involves bodily disintegration, not just a loss of responsiveness. Dr. Byrne emphasizes that real death is marked by cessation of circulation and respiration, followed by biological breakdown called autolysis. If the body is still integrated and functioning even with support, he argues that the person is still alive. 5. The stakes are ethical. Organ transplantation depends on the medical community embracing the concept of brain death. Dr. Byrne makes a direct and controversial claim that organs must be taken while still viable, and viable organs require circulation and oxygen, that is, a living body. Therefore, if brain death is not true death, organ procurement may involve ending a living patient's life. Because truth matters and human dignity isn't optional. This is Bioethics, Babe.